to invite Dr. K K Pareek, sir, ex-president API, ex-dean ICP, president Constitutional Committee of API, and founder president of Rajasthan RSSDI. Dr. K K Pareek, sir, is more than this for all of us. He is the mentor and fatherly figure for physicians of Rajasthan. He has been source of inspiration to all of us for last 30 years. He has been constantly motivating us for CMEs, seminars, and his motive is to disseminate the knowledge. Without wasting time, I request Dr. K K Pareek, sir, to say few words of blessing to all of us. K K Pareek, sir.
Thank you, dear Dr. Keswani, for your kind words. Or at the outset, I wish everyone happy Independence Day, and we should all together work for the taking India to a great heights. Today we have got case-based discussion, and I welcome all delegates attending this case-based discussion CME program. I welcome our past chairman, RSSDI Rajasthan Chapter, past president API, Dr. Girish Mathur, Dr. Keswani, our course director, and really a source of motivation to all of us for dissemination of knowledge, our dynamic organizing secretary, honorary secretary, Dr. G D Ramchandani. Today we will have a case will be presented by Dr. NIMISHA JAIN, a senior endocrinologist, Santokh Durlabji Hospital, Dr. Ajay Shah, HOD, Santokh Durlabji Hospital, Dr. S Dariya, Assistant Professor NIMS, Dr. Abhishek Prakash, Endocrinologist, will all be moderating the session, and I think we will have much more knowledge after listening to all this discussion. I hope we will have a very active discussion, and thank you very much. We will continue. Jai Hind. Thank you.
Thank you, sir. Thank you very much for your kind words. Now I invite Dr. Girish Mathur, sir. He is ex-president API, dean-elect ICP, ex-chair Raj RSSDI. His continuous efforts only has taken Raj API to present heights. This program of case-based discussions was started with his inspiration and motivation only, and it is running well for last 15 months. Without wasting time, I request Dr. Girish Mathur, sir, to bless us with a few words.
Thank you, Prakash ji, for the kind words. My greetings to you all on Independence Day. It's a pleasure to join this case-based discussion program on diabetes organized by RSSDI Rajasthan Chapter. It's truly heartening for all that this program is running successfully for over 1 year and is benefiting immensely to all the participants. My sincere thanks to Dr. K K Pareek sir, our mentor, for all his encouragement, blessings, and guidance. My compliments to Chairman RSSDI Rajasthan Chapter, Dr. Prakash Keswani, for taking the lead to organize this program very successfully. His efforts are truly commendable. Dr. G D Ramchandani, Secretary RSSDI Rajasthan Chapter, deserves a special mention for all his efforts and help for making this program a success. I welcome today's speaker, Dr. NIMISHA JAIN, Consultant Endocrinologist, SDMH Jaipur, the distinguished panelist, Dr. Ajay Shah, Head Department of Endocrinology, SDMH Jaipur, Dr. S Dariya, Assistant Professor, NIMS Jaipur, Dr. Abhishek Prakash, Consultant Endocrinologist, Mangalam, Medicity Jaipur. My sincere thanks to all the participants for their valuable presence for making this program success. My best wishes for today's program. Thank you so much, Prakash ji.
Thank you, sir. Thank you for your kind words. And without wasting time, I now request Dr. NIMISHA JAIN to please start your case.
Yes, sir. Thank you for this opportunity, sir. Today I'll be discussing, sir, I hope the slides are visible.
Yes, visible.
Yes, ma'am.
Yes. Today I'll be presenting unusual manifestation of a common endocrine emergency that we see day in, day out. That is basically diabetic ketoacidosis, DKA. So this boy, 21 years old, Mr. SK, resident of Ludhiana, presented to us while I was doing my DM. He was unmarried and he got admitted in October 2016. So his presenting complaints mainly were only involuntary movements of the left side of the body, the left upper body, for past 1 day. He was diagnosed with type 1 diabetes in November of 2015. At that time, he had fever, altered sensorium, pain, abdomen. His blood glucose was 550 milligram per deciliter. Blood ketones, that is beta hydroxybutyrate, was 5.7 millimoles per liter. pH was 7.2 and HbA1c of 14.3. So at that time, he was correctly given a diagnosis of diabetic ketoacidosis. At that time, because he had fever along with altered sensorium, a CT head was ordered, which was normal, and he was started on insulin. At that time, he was given regular insulin thrice a day with basal NPH. However, the compliance was poor. He had a repeat admission with DK in March 2016. Now, for last 1 month, he was also having low-grade fever, cough with mucopurulent expectoration. A chest X-ray was suggestive of pulmonary tuberculosis, and he was started on ATT from outside. This is 1 month prior to the current presentation. So he was already taking ATT for past 1 month at the time he had presented to us with the involuntary movements. Now, talking about the involuntary movements, they were there only for past 1 day. They involved the left upper limb, distal more than the proximal. They were purposeless, rapid, jerky movements involving the distal part of the left upper limb. Also, the proximal part showed some flinging movements in between, which were involuntary. And these movements decreased while the patient went to sleep. At this presentation also, because again, he is a frequent offender of leaving insulin. So again, in this presentation, his blood glucose was 645, serum ketones, that is the beta hydroxybutyrate, was 6.4 millimoles per liter, pH was 7.2. So this was the initial evaluation in the emergency. So basically, again, this time he is presented with DK. But the important thing about this time presentation that he had 1 day of involuntary movement, which involved the left upper limb. So to see whether the left upper limb involvement had to do something with the other than DK, so the negative history was taken. There was no history of any recent sore throat or joint pains or any rashes on the body. There was no history because Punjab is a frequently known place where drug abuse is very common. But this boy did not give any history of any drug intake or high-risk behavior, also confirmed with the mother. There was no similar family history. There were no other neurological deficits apart from this involuntary movement in the single limb. There was no history of any deep jaundice and no history suggestive of thyrotoxicosis. Now, this patient was conscious, oriented to time, place, and person. His vitals were stable. The general physical examination was grossly negative. He did not have any thyromegaly or lymphadenopathy. The systemic examination, the cardiovascular system, because also this might be the presentation of infective endocarditis also. So there were no murmurs and the heart sounds were normal. Chest examination mostly was normal. Abdominal examination did not show any hepatosplenomegaly. Coming to the CNS examination, in the higher motor functions, he was conscious and at that time oriented to time, place, and person. Motor examination, the bulk was comparable in all the 4 limbs, but there was hypotonia in the involved left upper limb. However, the power was normal, the DTRs were normal, and the plantars were bilateral flexor. The sensory and the cerebellar examination was all grossly within normal limit. The gait of the patient, because he was conscious and well-oriented, so we could ask him to move around, and the gait was also normal. And the abnormal movements, I'll show the video also. So there's a particular sign with these movements, which is called the milkmaid sign, that was positive. So if we can see, this was the presentation. So we can see that there is rapid, involuntary, jerky movements of the left upper limb. And these involved only the left upper limb, because in the right upper limb, there are no such movements. Along with that, in the proximal part, we see that infrequently there were flinging movements in the proximal part of the left upper limb also. So this video was taken on day 2 or day 3 of the admission. Okay. So coming on to the investigation, hemoglobin was normal. So also this presentation of chorea may be seen in acanthocytosis. So a peripheral smear specifically for acanthocytes was ordered and it was negative. ESR was okay. Rest of the investigations like urine routine showed sugar 2+, showed ketones, but there was no protein at present. Coming on to the other investigations, his electrolytes at this moment were normal. Renal functions were normal. At presentation of DK, he had hypophosphatemia but got corrected later on. His liver function test was normal. Also, the patient did not complain of any jaundice. If we see the lipid profile, there was hypertriglyceridemia at the time of presentation with DK, which is usually seen. There was no involvement of the pancreas in terms that amylase lipase were normal. Looking at the ABG, at presentation, the pH was 7.2, but it got corrected within the next 36 hours. The pH became 7.36 with an ion gap of 12. And the blood ketones of beta hydroxybutyrate reduced from 6.7 to 0.9 after the insulin infusion and the fluids. His HbA1c, as he is a frequent offender of leaving insulin, so definitely it is uncontrolled, is 15.8. The patient also had low T3 and low T4, which may be because of the presentation as such, it may be sick thyroidism also. TPO was negative. TPO was done because the patient was type 1 diabetic. So definitely we had to rule out autoimmune involvement of the thyroid gland also. Vitamin D was low. TTG was also negative and the GAD65 antibody panel was positive. Now, because the patient had been on ATT and the patient had pulmonary coughs, so we had to rule out, in case of any CNS involvement in this situation, we had to rule out the involvement of CNS in terms of tubercular meningitis. So a CSF workup was also ordered. ADA was normal and the protein was also grossly normal, the CSF protein. If we talk about the other etiologies of chorea, so the ASO titer was done, ceruloplasmin was done, the viral markers were done, ANA was done, ammonia level were done, echo was done, so it did not show any infective endocarditis. Also because chorea may be the presenting manifestation for Huntington, so with the help of one of the consultants, we send the patient sample for genetic analysis for Huntington's disease, and that was found to be negative. So we got this genetic test from Gangaram Hospital, Delhi. There was no KF ring. All the cellular plasmin levels were also normal. The bronchoscopy, because the patient was in ATT only for the chest X-ray finding, and there was no AFB. So went ahead with getting a bronchoscopy, and the TBLB, the biopsy showed granulomatous inflammation, which showed AFB positivity. So patient was continued with ATT. Now coming to the presenting manifestation, why the patient had these involuntary movements. So the imaging was done. First and foremost, the CT was done in the emergency itself. So this CT showed hyperdensity. If we can appreciate, the CT showed hyperdensity in the left caudate and the striatum area, which was confirmed further on the MRI. In the T1 imaging, we can see the hyperintensity, and also we can appreciate that there is also the dilatation of the ipsilateral horn of the frontal. So basically, the patient had hyperdensity in the CT and hyperintensity on T1 imaging of the MRI in the caudate and the striatal area. Whereas if we compare with the other side, there is no such hyperintensity on the other side, but on the affected side, there is hyperintensity on the T1 imaging of the MRI. This was further confirmed with the FLAIR imagings, and also because the patient had pulmonary involvement. So the CT chest was also done, which showed consolidation with tree bud appearance almost, and also because the biopsy confirmed AFB positivity, so the patient was continued with ATT. Now CT showed hyperdensity in the right caudate and the lentiform nucleus, and MRI T1 imaging showed, and also the FLAIR showed hyperintensity with atrophy of the right striatal region, and that is why there was dilatation of the right ipsilateral horn. So radiological diagnosis, what they had given was diabetic striatopathy. So this was the radiological diagnosis which was given by the MRI team. It said that patient in the outset had diabetic ketoacidosis, uncontrolled diabetes with hyperintensity in the striatal region. So basically this is diabetic striatopathy. Now the course in management, patient on type 1 diabetic on category 1 ATT for pulmonary tuberculosis presented with DK and hemicoria, received insulin infusion. The DK resolved in next 36 hours, but the movements persisted. MRI showed hyperintensity in the head and body of the caudate nucleus part. Workup for the other etiologies was negative, including the Huntington's disease. So this was diagnosed as diabetic steatopathy clearly on the imaging. He was added with haloperidol and escitalopram. Movements had reduced at the time of discharge, but did not resolve completely. So it might take time. So final diagnosis was type 1 diabetes with recurrent decay resolved at the time of discharge. Pulmonary tuberculosis on category 1 ATT for past 1 month with diabetic steatopathy. So patient came 5 months later, again with the episode of decay because again left insulin. And however, the patient had continued escitalopram and the coriform movements showed marked improvement. So if we want to see, and also because at the time of first presentation, the T3, T4 levels were reduced. So we got a repeat TFT done during the follow-up and that was found to be normal. Now this was on the follow-up. So this is 5 months after the initial presentation. If we can appreciate in the video, the movements have markedly reduced. Vis-a-vis, if we want to just see the prior presentation, so this was the presentation and the patient had presented with the involuntary movements. So this was at 6 months follow-up. This was the MRI brain. So we can see that the hyperintensity has resolved. However, the dilatation is still there because it has gone into atrophy and with some mineralization or the deposition in the caudate area. So these were the follow-up imaging. Sir, should I give?
This seems to be very interesting.
Yes,
and if not rare, at least uncommon. And this kind of picture presenting with the uncontrolled diabetes or decay is not usually seen. So what you think that can be because of the diabetes, uncontrolled diabetes or ketoacidosis or some acid-base abnormality? Why did it?
Yes, sir. This has been this entity has been there for a long period of time, but usually it comes with elderly patients who present with hyperglycemic coma. So this entity is quite common with elderly patients who present with type 2 diabetes in hyperosmolar hyperglycemic coma. But however, there are at that time, sir, we published this paper at the time of 2016-17 when we did the research. At that point of time, only 15 cases with DK were reported, whereas numerous cases in hundreds were reported with hyperglycemic coma. So they say that the etiology, the pathophysiology behind this condition in HHS hyperglycemic coma vis-a-vis diabetic ketoacidosis is entirely different. So in HHS, it is mainly because of the GABA-related metabolism, whereas in DK, it is mainly because of the shift of the osmolarity shift that happens, and mostly because this area, the striatal area, is the most metabolically important area and most metabolically active. So this is the area which is affected mostly in the DK or the HHS patient.
Okay.
So, Dr. Nimisha?
Yes, sir.
Any metabolic, as a general rule, we were taught in general medicine, if you have a lateralizing sign, think of a vascular or a neoplastic origin.
Yes.
Conversely, if it's a metabolic etiology, it should be bilateral.
Yes, sir.
So what is the explanation that why a diabetic, which is a metabolic thing, should be affecting only unilateral part? First question. Second, usually hemibellismus and all those regions which cause these movements are subthalamic but here the striatum is involved and causing hemibellismus. Is it a common entity? And third,
Korea.
Yeah, this is chorea, but I think that left arm in that, some degree of proximal movement,
Yeah.
that arm was swinging.
Yeah. Yes, sir. Definitely.
Could be Bellismus. You can debate on it. But basically that area, once we talk of a neurological diagnosis, we need to specify the anatomical diagnosis also. So usually in such parts, either the subthalamus or midbrain substantia nigra, and that area would be involved. In this patient, this was not there. So two questions. One is the lateralization, unilaterality in a metabolic situation, and second, the involvement, particularly again in just one side.
So actually, we are quite right that usually the neoplastic situations they present with unilaterality, but in this situation, definitely we have ruled out the neoplastic etiology with the imaging. And also it might be there that the patient might go on to become bilateral in some point of time if he had not presented as early as he did. So even with the one-day presentation, he came, although he's a frequent offender of taking treatment, but still I don't know why. Even after initial 1 day of abnormal movements, he presented. So probably if he could have waited for some more few days, then probably the bilaterality would have come. I'll show you the other patient who had presented at the similar 6 months later. So this was the other patient's MRI, which was the bilateral involvement. So this patient had presented, but this patient also had more in the right side than in the left side. So it is well known that these patients may present with unilateral or bilateral. So the presentation can be both, because the metabolic abnormality, we can't say that it might take time. It might have developed on the other side also if the patient would have waited for more metabolic derangements. So probably the DK brought him earlier, and so that is why we found only the unilateral involvement. And regarding the chorea bellismus, usually the striatal, the caudate nucleus and the lentiform nucleus, which leads to involvement of the chorea bellismus or the hemichorea or hemibellismus kind of movements. So this patient are typically in the striatal, and in all the patients, this is called stritopathy only because it has the striatal involvement. And the explanation which has been given is that they are the maximum density of dendrites and the maximum metabolic activity in the brain is in the striatal region. So that is the explanation which has been given in all the case series that we have gone through.
Excellent case, ma'am. It's a really very unusual and very uncommon case. But it's only day one he presented with this chorea and hemibellismus. Okay. But why you think about the Huntington's? Because that it never develops like acute. Why you think of that Huntington's?
I agree. We never thought of Huntington's in the initial part, but when there was pressure of publishing this case, at that point of time, we got the Huntington disease genetic workup done. So that was done for the sake of publication only. We didn't. That is one of the DDs in Korea, but that was done entirely for the publication purpose.
Yeah, because
I think at age 21,
age is also not
they are justified.
Yes.
it's almost third or fourth decade patient presented with Huntington's.
Yes,
and
sir.
our patient is only 21. So what is the explanation that patient is still not on controlled blood sugar, but the chorea is improved? Because
So
you said na, he again presented with the DK. So
Yes.
he might have uncontrolled blood sugar, but the treatment escitalopram is just for the movements. But the uncontrolled sugar was there, but still his chorea was improving. How it was?
So this patient, he used to take treatment in between, but for a day or two, he used to leave insulin. So the repeated presentation for DK were again and again for the sake of leaving insulin for a day or two in the duration of treatment. So this patient, he used to take in between, because when he used to stay with the parents and mother, they used to ensure that this patient was taking insulin. But in between, for like every 6 monthly, when he used to go out with friends or go out for traveling or that sort of thing, then for a day or two, and he used to leave. So probably in between this time, he was probably with better control, because in the first presentation, the HbA1c was 15, but in the second time when he came for a follow-up only for the DK again, at that point of time, his HbA1c was 8.5. So he presented with DK that time because he had left insulin for 2 days. He had gone for someplace outside and he forgot to carry insulin with him. So probably his metabolic parameters had improved in between, but because he had left insulin, so he again landed with DK.
So he has a history of 5 years only with the diabetes, right?
1 year, sir.
Only 1 year.
1
So
year.
it is very fast that he developed the striopathy. It is mentioned in the literature that somebody only last 1 year can develop this diabetic striopathy.
Sir, with type 1 diabetes, only 15 cases are published with striatopathy because it is a common occurrence with type 2 diabetes with hyperosmolar coma because the osmolarity shift there is very huge. Whereas in diabetic ketoacidosis, the osmolarity change, as we know, is not that big. So there are only 15 cases, including the 2 from our side, from our center. So prior to that, only 13 cases are there. So that's what I was saying, sir. In all the 13 cases, the presentations is quite different. So we cannot actually generalize that even after 1 month or 1 year or 2 year or 5 years, that how much time it will take for a patient of DK to develop striatopathy. So that is actually not clear, sir, because the case series which has been reported is very, very small. So probably if we have more numbers or more numbers from a single center, then probably we can give a better answer.
Okay, so it is more common among type 2, but again, by chance or what we can say that most of the times we usually do not see, possibly we do not think that it is occurring because of this striatopathy, and some abnormal movements occurs also in elderly patients with hyperosmolar coma. We usually ignore them to being a striatopathy, and of course in type 1 it is rare. We have seen only few cases are reported. And this seems to be again because of hyperosmolarity, because of the uncontrolled diabetes. I think so, right?
Yes, sir.
Okay, you can move further. We can move further discussion also.
Okay, sir. So if the time permits, I'll just go through briefly.
Yes, you can continue.
So as we all discussed, it's an underdiagnosed complication of diabetes. It is a constellation of neurological abnormalities because striatopathy, it's not only a MRI diagnosis, it's a constellation of neurological abnormalities defined by characteristic dyskinesias in form of chorea bellissimus, as Dr. Shah rightly pointed out, and striatal abnormalities on neuroimaging. So it has to be both of them. The MRI must be showing something on the imaging, and there should be dyskinesias in form mostly of the chorea bellissimus type. And it's a microangiopathic CNS lesion which is confined to the corpus striatum, which includes the caudate nucleus, the lentiform nucleus, and the putamen. It's usually reversible with restoration of the homeostasis, and it's commonly reported in elderly females with HHS, and it's rarely seen in patients with DK. So till date, 14 cases, including the present case and also 1 case later on that presented. So total 15 cases we have gone through, but this is till 2017, sir. Probably some may have cropped up. I have not searched that. There are only 15 cases documented in DK. Median age, even for DK, was 50 years. Resolution, because it's again a skewed thing, only less cases are there. Resolution time is from 2 to 28 days. So usually by 1 month, they resolve. Upper limb, lower limb, hemifacial involvement in different combination. It was bilateral in 2, bilateral upper limb in 2, bilateral lower limb in 1, bilateral lower limb with right upper limb in rest of the patients. So this is mainly in HHS, as I was saying that it has to do with the metabolism. So in hyperglycemic crisis, the Krebs cycles get suppressed and the cellular metabolism shifts, and GABA metabolizes to succinic acid. Because the GABA metabolizes to succinic acid, there's depletion of the GABA. This leads to disinhibition by the disinhibition of the thalamus, and that is why there is hyperkinetic movement. Whereas now why it is rare in DK, because the acetoacetate which is produced during diabetic ketoacidosis from the liver is available for the GABA production. So it is not GABA depletion in DK, and that is why it is seen very rarely in DK. If we see, so these are all postulations because less patients are there. So these are postulations. Nobody has ever. This is only on the basis of what the histopathological diagnosis comes out in any patient. So in one of the patients, the autopsy was done because the patient died. So from that patient, from the autopsy finding, these pathophysiology has been postulated. So because there is hyperglycemia, hyperviscosity, hyperosmolarity, which disrupts the blood-brain barrier, and there's global decrease in the regional blood flow that leads to within the cell acidosis, the metabolic failure, and cytotoxic edema. And there is, because of the cytotoxic edema, there's vascular insufficiency mostly in the striatal region. that leads to infarction and the hemorrhages in the striatal region. And because of the ischemia, there is swollen astrocytes and neuronal dysfunction. And this hyperglycemia may also affect the dopaminergic or the GABAergic activity. So, because as I said that in one of the patients, the autopsy was done in 1998. So the histopathological finding from the striatal region was that there was the vascular involvement in terms of vascular proliferation, arteriolar thickening, gemcistocyte accumulation, inflammation, and but there was no evidence of demyelination. There was no demyelination in the CNS system in that patient. So on this basis of this, that there is vascular insufficiency, the postulations has been made. So vulnerability to this obliterative vasculopathy is restricted mostly to the striatal area of the CNS. And why? Why? Because it's highly susceptible to metabolic derangements, high metabolic requirements to supply large number of synapses which are formed in the striatal region. It mainly contains the highest density of dendrites. And these are the findings. As I said, in the T1 weighted MRI imaging, there is hyperintensity in the basal ganglia. So in some people, they have done spectroscopy also. In the spectroscopy, they have seen there is certain kind of acetyl aspartate to creatine ratio shift. But in this patient particularly, spectroscopy was not available. So these are the differential as sir was asking me. So mostly hepatic encephalopathy, that is the most common. But in this patient, the LFTs were normal. The patient did not have jaundice and he was not a drug abuser. Apart from that, these may be seen in HIE, also in hypoglycemic coma. Recently, while working in private practice in 2022, I came across a patient who presented with hypoglycemia, type 2 diabetes. He presented with hemichoria. So also in that patient, the MRI suggested the similar finding of striatopathy. Also in Wilson, Sydenham chorias and Huntington's chorea, these are the common differential. But as sir rightly pointed out, Huntington is not without the family history, and also the presentation is usually later on in the 3rd to 4th decade. But now, coming on to the prognosis, as sir was asking that how it got resolved. So the persistence of radiological lesion may be there, but mostly 90% of the patient, they have a complete clinical resolution with the metabolic improvement. And with the immediate metabolic improvement also, the clinical resolution happens, because in certain cases, the resolution has happened as early as 2 to 8 days also. And the maximum time that has been taken is 28 days. And in our patient, we don't know exactly when it got resolved, because the patient came for follow-up after 5 months after discharge. So as per the patient said that after 1 month, they started improving, but we exactly don't know. So mean time for other patients have been 2 to 28 days. So patient have immediately improved with the correction of decay also. So it might not be that the patient needs to maintain a good glycemic control over a long period of time for these not to resolve, but the patient may resolve immediately with the resolution of the immediate problem, by whether it is HHS or decay. And it may be in HHS. So this may be a presenting, the patient who came, as sir was asking that why only 1 year. So in some of the patients, it may be a presenting manifestation of diabetes. So we may miss that also, and no specific correlation with initial blood glucose, duration, and osmolarity has been noticed. It takes longer time for resolution in poor diabetes control, and especially in the elderly patients. So this case was published in DRCP later on with the clubbing with the second patient. So this was the second patient, as sir had asked me whether bilateral involvement. So this patient had bilateral involvement, and this patient also the right involvement was more than the left involvement. So it might be there that this patient may also, the current patient may also present with bilateral involvement if the patient would have taken more time to present. So just I could think of only these learning points. Let's check blood glucose in patients with acute onset hyperkinesia. That is very important. And early recognition and treatment are also rewarding. And as Keswani sir rightly pointed out, that with HHS patients, we usually, because they are elderly patients, we usually miss the hyperkinetic movement. So if we start getting done the MRIs, and probably the number of patients who present with striatopathy will get bigger, and we will start getting a bigger cohort rather than seeing less number of patients. So thank you very much.
Thank you,
So,
Dr.
thank
Nisha.
you, Dr.
Really, it was an
Nisha.
interesting case. And
Just quick questions. So in that series of 14 patients, other than the index case, how many had tuberculosis? Because this index patient had tuberculosis, Did any other patient have tuberculosis?
No, none patients, sir. Mostly these patients, the other 12 patients were not from India. So mostly outside India, the tuberculosis is not that common reported. None of the patients reported tuberculosis.
And second question would be, think other way around. How many chorioathetoid patients will have diabetes? Think other way around. The prevalence of diabetes in patients who have got chorioathetosis. Any idea?
So mostly chorioathetosis, if it presents in the elderly patient, then probably it is they're presenting with type 2 diabetes. And as we know, the prevalence is quite high. Exactly what prevalence is there, I don't know. I don't know what to comment on this. But
Ajay sir, we can
search it.
We can get the answer. Ajay sir, we can get the answer of this, that how many patients of chorea or athetosis or patient having diabetes. The only answer that if we'll get the fifth vital as a blood sugar, then only we will know that how much of the incidence is there in every disease, not even in the chorea or the hemivalismus or the other things.
Excellent case, ma'am. I just want to ask two things. First, obviously the abnormal movements were there. So was there any posterior relation of these movements? In both the videos that you showed, the movements were exaggerated in hyperextended position. So was there any change in the position at rest and while doing the examination, ma'am?
Any other question also? Or should I come with?
Yes, the other question is there was a discussion going on despite metabolic condition, the imaging structural finding was on one side. So I would just like to add that many a times in cases of congenital hypoparathyroidism, we get such type of movements, the flinging movements, the chorea, balismatic movements. So in those cases also, if we do imaging early on, we may get asymmetric hyperdensities in the imaging. So I think that adds to the context that many a times, despite the etiology being a metabolic one, the imaging may be different. It just depends on the temporal sequence, as you highlighted out. So I want to add that angle, ma'am.
Yeah, exactly. It's also one of the DDs. The hypopara is also one of the DDs for dyskinetic movement. And as you asked me about the first, yes, you are very rightly pointed out. We asked the patient to extend because otherwise the proximal flinging movement, which was seen while extending the arm, was not there while the patient was resting his arm. So while the patient was resting his arm, the distal movements were still visible, but the proximal movements were not that visible. So for the sake of good picturization, we asked the patient to extend, and also while sleeping, the movements had markedly reduced. So with the posture, yes, while the patient was resting the arm, there were mostly distal movement. The proximal were probably, they might have been there, but they were not that well nicely appreciated. So that is why we asked for the hyperextension of the arm.
And there's a question in the chat box.
Yes,
how you explain the low T3, T4 and TSH?
Yes, sir. Probably initially the TSH was okay, the T3, T4 were low. So that may be a part of the non-thyroidal illness or the CQ thyroidism that we correctly know as. Because this patient was definitely type 1 diabetic, there was a possibility of the autoimmune involvement. So the autoimmune involvement also in type 1 diabetes may be at the primary or the secondary level. However, the TPO antibodies were negative, and later on the T3, T4 levels, they got, once the patient had better metabolic control, they got improved. So probably at that point of time, it was a part of the non-thyroidal illness or the CQ thyroidism syndrome that we usually commonly use the term for that.
And once patient improves, becomes euglycemic, and these movements are also improved, what happens to these hyperintensities in the brain?
Yes, sir. So the 15 cases that we have reported showed that the approximately 2/3 or the 3/4 of the patient, they improved with radiologically. The one patient who had died and on which the autopsy was performed definitely did not get that much of time for a repeat radiology. But it is said that 90% patients' movements improve, but it is not always that there is radiological improvement. There may be some part of radiological abnormality that may remain behind.
Okay.
So Dr. Nimisha, another question from the chat box. It's not my question. were the adrenal functions normal?
So adrenal function at that point of time were not done.
I think I agree. For this patient, I don't think so. Cortisolism was ever involved.
Any
Yes,
other
it was-
comments?
Yeah.
I think it was an interesting case and make us cautious that in future also when we see the hyperosmolar patients, hyperosmolar coma patients, and we find the abnormalities, abnormal movements, we should always think of these and work up for these also. As there are no other comments, I would like to thank Dr. Nimisha for presenting a nice and interesting case, Dr. Ajay Shah, Dr. Abhishek and Dr. Dariya for their active participation and making this session lively. I like to thank all of you, and I am happy that Dr. R.P. Pareek, the senior physician from Rajasthan, and Dr. Paduman Sharma and many of the senior physicians have also joined. And again, next month on third Thursday, we will meet for this case presentation. Thank you all.
Thank you, ma'am.
Thank you.
That was
Thank you for
really
the
very good
opportunity,
case. Thank you, ma'am.
Felt like going back to my residency days.
Thank you.